just a few words about injection of these agents. We want to inject dynamically. What that means from my perspective is basically that as we perform the injection, we're lifting the needle toward the center of the lumen so that we're sort of shooting the fluid into the upper layers of the submucosa. That's the key aspect, I think, of dynamic injection, is that you're moving the needle, especially moving it toward the center of the lumen, lifting the tissue. And then we want to inject with a strategy. So for a lot of smaller lesions, this is a small adenoma, maybe 20 millimeters. It's best to inject right in the center of the lesion, right through it, so that the lesion ends up on the top of a dome of fluid. Serrated lesions, if we're going to inject those, almost always best to inject through the lesion because they tend to not be enormous. A lot of times I like to inject them on the cecal side, a little bit on the cecal half, in order to tip it toward me. And this approach is generally best for smaller lesions and for serrated lesions. There certainly are a set of lesions where we want to inject on the proximal edge of the lesion. And sometimes that's difficult. I always say you should never overestimate how much polyp tissue can be on the other side of a fold and not visible to you if you can't see the actual edge. And so it can require some special tricks to try to get as close as you can to that proximal edge of the lesion. Sometimes some initial injection will tip the lesion up enough that you can get at it. This is an example of going into retroflexion to do it. I think this is a maneuver that we all should be able to do. Very helpful for lesions that are on the medial wall of the ascending colon near the hepatic flexure. And in this lesion, we're going into retroflexion below it, and then are going to make the injection again on that proximal edge. And the strategy is chosen here because this lesion is sort of draped over a fold and it's hard to access the proximal side of the polyp. In many cases, we don't need to do the resection from the retroflex position if we've injected it well, but we might choose to because sometimes that's easier also. This is a lesion that's down in the cecum. And again, you can see that it doesn't look perhaps like there's a lot of lesion that's on the other side of this little fold down in the cecum. But again, you should never underestimate how much polyp may be over there. So I tried several different tricks, ultimately sort of started injecting at one end of it. And if you get a little bit of a mound of fluid starting to build up and pushing that edge up, then you can follow that initial mound down around the proximal edge, the cecal side edge of the lesion, and be able to inject well. But you'll see here as we do that, as we move from right to left, there's a significant amount of polyp that was hidden. That's kind of useful for us to be exposed. One of the things I get referred from to me from doctors is a partially removed polyp. And it's not uncommon that the part that is on the anal side, on the anal side of a haustral fold has been removed, and the part that was on the proximal side was left in place. So, and then with the much larger lesions, this is a granular lateral spreading lesion that is located in the cecum. The usual strategy is to inject and usually on the anal side, create a mound, resect that, and then move on to the next part of the lesion. I saw one paper from the Netherlands, and we have seen a lot of work in the US showing that lots of benign colon polyps, and this lesion being a granular LST has very little chance of having cancer in it, but they are actually sent to surgery, probably because of concern about complications. And we're trying in the US to make the point with gastroenterologists and other endoscopists that size alone should not be an indication for surgery, because these lesions are typically quite straightforward to remove. To do this relatively safely, we typically use snares of about 15 to 20 millimeters in size. They tend to lift extremely well. We can start at one side and just move progressively over to the other side. But this is a somewhat different injection strategy than we would use for a lesion that's draped over a fold, or the smaller typical 2 to 3 centimeter lesion that we want to inject to perform EMR.